palatine tonsil, or generally they are called as tonsils. These tonsils are the almond shaped masses of the lymphoid tissue which are located in the tonsillar fossa. And this tonsillar fossa is present in the lateral wall of the oropharynx. Here you can see the uvula, this is uvula, and from the base of uvula this fold of mucous membrane is arising. This is the anterior fold and this one is the posterior fold. Anterior fold is formed by the palatoglossal muscle and the posterior fold is formed by the palatopharyngeal muscle. Now coming to the boundaries of the tonsillar fossa or the tonsillar sinus, this anterior boundary is formed by the palatoglossal arch and the posterior boundary is formed by the palatopharyngeal arch. Palatoglossal arch contains the palatoglossal muscle and the palatopharyngeal arch contains the palatopharyngeal muscle. And apex of this fossa or the tonsillar sinus is formed by the meeting of these two muscles or the arches, and the base of this fossa or the sinus is formed by the posterior 1/3 part of the tongue, and the lateral wall of the tonsillar fossa or sinus, that is mainly formed by the superior constrictor muscle. So this was the tonsillar fossa or the tonsillar sinus. Now coming to the tonsillar bed, which is forming the lateral wall of the tonsil, and it is from within outwards or from medial to lateral. It is formed by three structures: pharyngobasilar fascia, this is the pharyngobasilar fascia, then the superior constrictor muscle, and the green dotted line is showing the buccopharyngeal fascia. So medial to lateral, these three structures are forming the tonsillar lateral wall of the tonsil. These are pharyngobasilar fascia, superior constrictor, or the buccopharyngeal fascia. These three are forming the tonsillar bed. Now the external features, it has two poles, upper and the lower pole, two surfaces, medial and the lateral surface. This is the medial surface, this one is the lateral surface, and the two borders, anterior border and the posterior border. Anterior border is related with the palatoglossal muscle which forms the palatoglossal arch, and posterior border is related with the palatopharyngeal muscle forming the palatopharyngeal arch. And this is the lateral surface having a capsule, that is the extension of the pharyngobasilar fascia. Now the medial surface, you can see on the medial surface large number of crypts are there. They are 12 to 15 in number, and the uppermost crypt is the largest one, and that is called as crypta magna or the intratonsillar cleft. And this crypta magna represents the remnant of second pharyngeal pouch. And this medial surface is bulging into the oropharynx, and so it is lined by the lining of the oral cavity or the oropharynx, that is stratified squamous epithelium which is non-keratinized. So the lining, the medial surface which is bulging in the oropharynx is lined by stratified squamous non-keratinized epithelium. It is having large number of crypts, that is around 12 to 15, and the uppermost crypt is the largest one or the deepest, that is called as crypta magna or the intratonsillar cleft, and this represents the remnant of the second pharyngeal pouch, and this crypt may be filled with the cheesy material or the epithelial cells or the bacteria or the food debris. The lateral surface, it is covered by fibrous tissue which is forming a capsule or the hemicapsule which is present only on the lateral surface, and this capsule is modification of or it is extension of pharyngobasilar fascia. So this is pharyngobasilar fascia, the greenish one, and this is the lateral surface of the capsule, lateral surface of the tonsil. So this pharyngobasilar fascia forms the capsule on the lateral surface, that is called as hemicapsule, and lateral to the capsule there is a space that is called as, this space is pinkish one, that is the peritonsillar space. In this space you can see a vein, that is paratonsillar vein. and this space is forming the plane of dissection or the plane of surgery during tonsillectomy. But during tonsillectomy, as the vein is here, the chances of hemorrhage through this vein. And if the pus get collected in this space, that is called as peritonsillar space abscess, peritonsillar abscess or the quinsy. So, the lateral surface, it is covered by a capsule that is present only on the lateral surface. So, we call it hemicapsule, and this hemicapsule is extension of pharyngobasilar fascia. Lateral to lateral to the capsule, there is a space that is called as paratonsillar space or the peritonsillar space, and in this space there is a vein called as peritonsillar vein. And this peritonsillar space is a plane of surgery during tonsillectomy. And this peritonsillar space, if the pus is collected in this space, that is called as peritonsillar abscess or quinsy. Now the lateral surface, we have seen that on the lateral surface there is a capsule, then peritonsillar space, then pharyngobasilar fascia, superior constrictor, and then buccopharyngeal fascia. And lateral to the buccopharyngeal fascia, you can see the facial artery with its branches. The facial artery with its ascending palatine and the tonsillar branches, and styloglossus muscle and the glossopharyngeal nerve. Also a gland, that is submandibular salivary gland, and here you can see the mandible, angle of mandible with the medial pterygoid muscle. So these are the structures which are related with the lateral surface of the capsule, lateral surface of the tonsil. So what are these structures which are related with the lateral surface, or you can say these are the structures which are separating, which are lateral to the superior constrictor muscle, and these structures are facial artery with its two branches, styloglossus muscle and the glossopharyngeal nerve, angle of mandible with the medial pterygoid and submandibular salivary gland, and sometimes the styloid process if it is elongated. Now the other external features, anterior border of the tonsillar fossa or anterior border of the tonsil, it is related with the palatoglossal arch which contains the palatoglossal muscle. Posterior border of the tonsil is related with palatopharyngeal arch that contains the palatopharyngeal muscle. Upper pole of the tonsil, it is extending up to the soft palate. Here this is soft palate, this one is the soft palate. So upper pole of the tonsil is related with the soft palate, and the lower pole of the tonsil, it is related with the dorsal surface of the tongue or the posterior 1/3 part of the tongue, and it is connected with the tongue by a ligament that is called as suspensory ligament of tonsil. By this ligament, it is firmly attached to the tongue. That is why during swallowing, the tonsils will not slip. Now the blood supply of the tonsil, arterial supply. The main artery of the tonsil is the tonsillar branch of facial artery. Here you can see the facial artery, and here this is the branch, that is tonsillar branch of facial artery. This is the principal artery of the tonsil, and here you can see that it is entering through the lower pole of the tonsil by piercing the superior constrictor muscle. And what are the other arteries, other branches, other arteries which are supplying it? This is the dorsal lingual artery, which is the branch of lingual artery. Ascending palatine artery, which is the branch of facial artery. Ascending pharyngeal artery, which is the branch of external carotid, and the descending palatine artery, which is the branch of maxillary artery. So these are the arteries which are supplying the tonsil, but the main artery is the tonsillar branch of facial artery, which is the principal artery of the tonsil. Now coming to the venous drainage. Venous blood from the tonsil will enter into the paratonsillar veins, and that form a plexus around it, and from that peritonsillar plexus the blood will enter into the lingual vein or the pharyngeal veins, and that will enter into the pharyngeal venous plexus, and finally from the pharyngeal venous plexus blood will enter into the internal jugular vein. So finally the venous blood will enter into the internal jugular vein. Now coming to the lymphatic drainage of the tonsil. Here you can see the palatine tonsil. This is the palatine tonsil, and they are draining into the upper deep cervical group of lymph node and mainly into the jugulodigastric group of lymph node. So jugulodigastric group of lymph node are called as lymph node of the tonsil, and jugulo-omohyoid group of lymph node are called as lymph node of the tongue. So lymph node of the tonsil are jugulodigastric group of lymph node, and so they will be enlarged during inflammation of the tonsil. So in the tonsillitis, the jugulodigastric group of the lymph node will be enlarged, and where they are located, they are present just below the angle of the mandible. Now the nerve supply of the tonsil, it is from the glossopharyngeal nerve and the lesser palatine nerve. Lesser palatine nerve, that is a branch of sphenopalatine ganglia. Now we come to the applied anatomy of the tonsil. Inflammation of the tonsil or infection of the tonsil is called as tonsillitis. It may be acute or chronic, and these tonsillitis mainly occurs in the school going children. Why it is so? Because lymphoid tissue is maximum developed in this age group. In infants and above 50, this lymphoid tissue degenerates, so tonsillitis is very rare in this age, and most commonly it is in the school going children or the puberty at the age of puberty. And the lymph node will which will be enlarged during tonsillitis are jugulodigastric group of lymph node, because they are the lymph node of the tonsil. Now what is tonsillectomy? Removal of the tonsil is called as tonsillectomy, and during tonsillectomy we have to remove the capsule with the tonsil from its tonsillar bed, and the plane of dissection during surgery is the peritonsillar space, and during surgery the chances of hemorrhage by the if there is rupture to the peritonsillar vein, because these paratonsillar veins are present in the peritonsillar space and we are doing surgery in the peritonsillar space, so there are maximal chances of damage to the peritonsillar vein. So if there is excessive hemorrhage after tonsillectomy or during tonsillectomy, the blood is coming from the paratonsillar veins, and sometimes after tonsillectomy there may be loss of taste sensation from the posterior 1/3 of the tongue. Why this is so? If there is injury to the glossopharyngeal nerve, we can see that the glossopharyngeal nerve is related to the lateral surface of the tonsil. So if it is injured, then there may be loss of taste sensation from the posterior 1/3 part of the tongue. Now what is quinsy or peritonsillar abscess? If the pus is collected in the peritonsillar space, that is called as peritonsillar abscess or the quinsy. And how it is removed? From the site of maximum prominent point, the incision is made and the pus is removed. And we have discussed just that the bleeding from the tonsillar fossa after tonsillectomy is from the paratonsillar veins which are present in this space, and in order to stop bleeding we have to remove the blood clots which are present in the tonsillar fossa. But during all the surgeries except tonsillar surgery or the uterine surgery, we keep the clots in the clot after surgery, but during or after surgery of the tonsil and uterus, we have to remove the clots, because these clots will interfere the retraction of the vessels wall, and by preventing the contraction of the surrounding muscles which are forming the boundary of the tonsillar fossa. So after uterine surgery or after the tonsillar surgery, if there is any clot, we have to remove it because these clots will interfere the retraction of the blood vessels and they will prevent the stoppage of bleeding. So it will lead to bleed. So we have to remove the blood clots after surgery of the tonsil or the uterine surgery, and in rest of the surgery we keep the clots. Now the referred pain from the tonsil, the pain from the tonsil may radiate to the middle ear because having the nerve supply of the both structure is same. The tonsil is supplied by ninth nerve and the nerve supply of the middle ear is also from the ninth nerve. So referred pain from the tonsil will radiate into the middle ear. Now the internal carotid artery, it is present 1 inch behind the tonsil, but it is never injured during tonsillectomy or any surgery of the tonsil because the fatty tissue which is present around the internal carotid artery or around the carotid sheath, so easily we can separate the carotid sheath from the pharyngeal structure. We can separate the pharynx from the carotid sheath easily. That's why it is the artery which is present just 1 inch behind the tonsil, but it is never injured during the surgery. So that's all about the tonsil. Thank you.